everyone, and welcome to another episode of MedSynapse podcast series. Today, we delve into a topic that continues to evolve and spark interest within the medical community, which is thyroid nodule ablation. With its minimally invasive approach, this procedure offers new hope and alternative for patients who previously faced more extensive treatments. And joining us yet again is Dr. Rajesh Helavar. Dr. Rajesh is an esteemed interventional radiologist with over 20 years of experience in treating complex vascular and thyroid conditions. As a leader in his field, Doctor is celebrated for integrating advanced medical practices with compassionate care, ensuring optimal recovery and outcomes for his patients. His innovative approach and vast expertise contribute significantly to his reputation as a top-tier specialist in interventional radiology. So, Doctor, it is an honor to have you back with us.
Thank you. Thank you very much for having me on this forum again.
So, Doctor, to start with, can you share with us what role patient stratification plays in the success of thyroid nodule ablation, and how do you tailor your approach for different patient demographics, such as those with pre-existing thyroid disorders or autoimmune conditions?
Okay. First, coming to thyroid ablation, just let's give a brief introduction about what is thyroid ablation. So, people tend to have nodules in the thyroid gland, there's lumps in the thyroid gland. So traditionally, these lumps, they were called as colloid goiters. They were the only option to treat them, especially if they become symptomatic in the way of either cosmetic symptoms or they are compressing on the surrounding structures and causing symptoms by way of compression of either the esophagus or the trachea. The only treatment earlier was surgical removal of these nodules. So surgical removal involves making an incision under general anesthesia, taking either the nodule or the whole thyroid gland out. And the evolution of technology in ablation has resulted in this new technique called thyroid ablation. So in this thyroid ablation, what we do is a small needle is inserted into the thyroid nodule, the abnormal nodule, not the entire thyroid gland. And heat energy is generated by agitation of the tissue molecules. So then the thyroid nodule undergoes necrosis and shrinks gradually. So the differences between the conventional surgical method and thyroid ablation is that in conventional method, you need to undergo general anesthesia. All the thyroidectomies are under general anesthesia. In however big or small the nodule is, general anesthesia was must. Coming to thyroid ablation, most of these procedures can be performed under local anesthesia with mild conscious sedation. Most of our patients are actively talking. We encourage them to talk to identify any problems during the procedure. And the procedure is done in a short while. It takes a very short while to do the procedure. And most of them go back home on the same day, or in fact, even if the procedure is done in the morning, they go back home in the same afternoon after a brief observation as well. So the next question is, how do I select the patients for thyroid ablation? So in thyroid ablation, let's say patients who have autoimmune disorders and other things. So if we first have assessment along with an endocrinologist or an ENT surgeon, so it's a team approach, and we assess their thyroid antibody levels, their T3, T4 and TSH levels, and an ultrasound is performed for all of these patients. So if the ultrasound shows that the lesion is entirely just thyroiditis, the diffusely gland is involved as thyroiditis, and then we do not offer thyroid ablation as a first choice. If the patient has colloid goiter, what is most commonly seen, if there is a presence of colloid goiter, then the patient will undergo fine needle aspiration cytology, that is the FNAC test, to make sure that we are dealing with a benign nodule and not a malignant cancerous nodule. So once this test is done, we need at least two samples, two FNACs at separate intervals to prove that this is a benign nodule and not a malignant nodule. So once the patient satisfies all these criteria and his test come back as benign colloid goiter in the pathology report, then he's eligible for a thyroid ablation. Next, coming to the nodule itself. There are two types of nodules. One is solid nodule and there is a cystic nodule. and cyst meaning more of fluid, or there is a combination of solid and cystic. If it's a completely cystic nodule, that means containing more of fluid content, thick fluid content, the patient is eligible for what is called as ethanol ablation, in which a needle is inserted into the nodule and the fluid is all aspirated, cleared up, and alcohol is placed, absolute alcohol is placed inside the nodule and then left for a few minutes and then re-aspirated. This results in resolution of the nodule. If the nodule is solid, then we perform either radiofrequency ablation or thyroid ablation with microwave, either radiofrequency or microwave. If it's a combined lesion, we do a combination approach. So this is how we stratify based on the patient factors, the lesion factors, into what treatment the patient would need.
I think, thank you for actually briefly giving a introduction about what exactly thyroid nodule ablation is. And also it is so fascinating to see how actually patient stratification can impact the outcomes of what thyroid ablation do you choose. So it's really interesting to know. So now, as we talk about post-treatment, so could you elaborate on the latest protocols or innovations in post-ablation monitoring and follow-up that help detect and manage potential reoccurrence or complications early? And also one more question was, how have these protocols changed your practice?
Okay, so coming to the prevention of complications and monitoring protocols, first is when we are doing the lesion ablation, we will always look if the lesion is very close to the nerve or very far from the nerve. So if the lesion is very close to the nerve, and as a protocol in all our patients, we intra-procedural, we will monitor the patient's voice to detect any changes, because there is a nerve called recurrent laryngeal nerve, which potentially can get damaged if the heat is excessive. So we will always monitor the patient's voice intra-procedurally. And the complications are extremely low. And second thing is, once we do the thyroid ablation, we do something called as contrast enhanced ultrasound, which is done with the same ultrasound machine with the injection of a small contrast, which is mostly air bubbles coated with the material. And this shows us that what is the area of the lesion that has been ablated completely. And it can be done on table when the patient is still on table. So this gives us an indication if there are any unablated areas which need to be targeted, we can target them and finish the ablation. This is during the procedure. The next, the patient comes to us after 1 month and 3 months for the follow-up. The reason being, the resolution of the nodule is not instantaneous, because the necrosis has to happen and then the slow shrinkage happens, peaking at about 6 weeks when we have maximum reduction in the size. So most of our protocols are to follow them up at 1 month and 3 months. So at the same time, 3 months time, when the patient comes to us for follow-up, we will again have a T3, T4, TSH to see if there is any alteration, which is very, very unlikely. So I follow these protocols strictly, and along with all my preoperative and assessment. So it helps in good patient selection. And another word, when the lesions are very large, what we do is we either offer them that, because this needs a multi-stage procedure of ablation. So we try and offer them surgery in this instance if they require one-step solution, or we offer them multi-stage ablation if the nodule volume is very high. In these patients who are large volume, we call them up after about a month for the second month to 1.5 months for the second ablation procedure.
That is quite insightful. And one more question I would like to ask is, what would that one advice be of yours be to the healthcare professionals that they should be looking out for when going for thyroid nodule ablation?
So for the referring doctors, they need to understand that this is this is not experimental. This is safe, proven beyond doubt that the thyroid ablation works. And there have been trials that there are randomized controlled trials of thyroid ablation with radiofrequency ablation, microwave ablation. And there have been comparisons between microwave ablation and thyroid ablation, and the results are good. And like I said earlier, most of these are done under local anesthesia with conscious sedation, requiring extremely low amount of hospital stay. Duration of hospital stay is extremely minimal, beginning from half a day to 1 day. Most of them are daycare procedures. We can do this. So I request our referring physicians to be aware of these advantages and techniques of ablation of thyroid nodules.
Thank you for sharing that piece of advice, doctor. Now, moving on, patient involvement in their treatment choice is key. So, how do you emphasize patient education and shared decision making when recommending thyroid ablation or over more traditional treatment options?
Yeah. When a patient comes to my outpatient clinic seeking thyroid ablation or is being referred to me for thyroid ablation by an endocrinologist or an ENT surgeon or a general physician, we sit down first and discuss with them that what are the treatment options available. We list out each of these treatment modalities and we say them, give them realistic expectations about when to expect the resolution with surgery, when to expect a resolution with thyroid ablation. This helps us in building a good platform because the expectation should be set right, because immediately after the procedure you cannot have an resolution of the nodule size. So the expectations have to be set right, and we also have them counseled regarding the monetary aspects as well. And most of my patients who come for independently directly come to me to see for seeking thyroid ablation always undergo an endocrinological consultation and an ENT consultation, video laryngoscopy. All the questions are answered, and that's how we take that forward. So it's a team approach always. So we make sure that all bases are covered, patients' questions are answered, and they're satisfied with them before we start the procedure.
Patient satisfaction is again the key, and I think empowering patients with knowledge is also very pivotal when undergoing such therapies also. So yes. Now, considering healthcare economics, I'm sure the cost will be higher. So, what is your take on the current cost-benefit analysis of thyroid ablation compared to traditional surgical options? Particularly in resource-constrained systems.
Okay, so coming to the cost of traditional thyroidectomy versus ablation, the costs are similar, not different. Thyroid ablation is not more expensive. It is not more expensive than surgery. So the surgical costs include the longer duration of hospital stay, recovery, and loss of ability to resume work immediately. Those are offset in the thyroid ablation because the patient can resume his duties if the nodule is smaller on the same day or sometimes the next day itself. So the cost of these procedures are almost equal in similar hospitals. So the cost can further go down if these devices which we are currently using were made in India. So I think there is some trend to make these devices in India. Most of these devices are currently not made in India. If there is these devices are available and made in India, I think there would be a further drastic reduction in the costs, and it would be less expensive than a traditional thyroidectomy. That's the way forward.
Yeah, I think that is like a layer of hope for a broader adoption as well. Now, so in cases where patients present with large or multinodular goiters, so how do you adjust your approach to ablation? And could you also share some technical challenges you usually encounter when treating these complex cases?
Larger nodules, we have three approaches in fact. So based on patient's criteria, so we can offer them three things. One is traditional surgery. If your result expectation that you need one-step procedure, you don't want multi-stage procedure, you can do traditional thyroidectomy and refer to your head and neck ENT surgeon. Always have that option open, never close the doors. Second option is where you will do a thyroid artery embolization. The artery that supplies the thyroid is blocked by a transfemoral or a transradial approach. You go into the vesicular system and you visualize the artery that supplies, and there will be a blush, and you block the artery that supplies the thyroid nodule. So that's called as a thyroid artery embolization, and then follow it up with a ablation. This is second approach. The third approach would be to do staged ablation, like do the one part of the nodule first and the second part of the nodule a few weeks later. So all three approaches will be discussed with the patients and tailored to his expectations and his medical condition. So these we have three approaches even for large multinodular goiters as well.
Yes, I think those technical challenges also sound significant, but it is also so impressive to hear you how you actually navigate them to ensure patient outcomes. So yeah. So now, lastly, doctor, could you shed light on any recent clinical trial findings or research studies that have shaped your understanding or approach to thyroid ablation, and how do these findings inform your future practice?
So there have been some technical developments in the terms of the frequency ablation antennas that are available. The needles are becoming slimmer, smaller in size, so enabling the smaller scar. Even this is a scar-free procedure. Even the needles are becoming smaller, meaning that the pain is going to be even less during the procedure. And earlier we used to have only unipolar RF ablation antenna, so that required an additional step of putting pads to ground the electricity. Now we are getting bipolar antennas, so that helps in reducing the procedure time because we don't need the grounding pads. Number three, we have microwave ablation devices now easily available, and microwave ablation results in faster treatment times. And now we have literature that long-term follow-up literature, especially from Korea, coming and telling that it is as effective as surgery. And there is comparison trials between radiofrequency ablation and microwave ablation, telling that both are equally effective. So the literature is abundant, and it's very important to be knowledgeable about these. So I currently do thyroid nodule ablation only for benign lesions, but there is a trend in Korea to treat smaller recurrent cancers of thyroid, and also to treat cancers in patients who are not eligible for surgery, like very elderly, not fit for anesthesia. So currently these are not in the scope of my treatment because we stick to benign lesions, and but the literature is evolving in terms of treatment for malignant nodules as well.
That is so fascinating, and I think staying informed through research is what actually keeps innovation alive in medical practice also. So thank you so much for sharing that as well. So now, as we wrap today's session, thank you so much for sharing these valuable insights with us, doctor. It was truly invaluable for us.
Thank you. It was my pleasure discussing things with you.
Thank you. And one last question is, how do you like the entire process and actually being the guest for the second time on our podcast?
Oh, I like this format where we discuss things from the patient's perspective, and also putting it across in the social media and other things, because I think interventional radiology is not a new specialty. For example, thyroid ablation, most people would either go to a general physician or to an ENT surgeon. So most of the procedures done by interventional radiologists are the general population is unaware. So I think you are taking the right step in terms of pushing the right information to the patients who need it. So interventional radiologists and interventional radiology needs to be publicized among everybody, so that they can directly access the health facilities that they need to.
Actually agree with you that spreading the right kind of knowledge to the right resources is really important as well.
Agree. Thank you.
Thank you. And to our listeners, I hope this conversation has provided you with a deeper understanding of thyroid nodule ablation and its evolving role in patient care. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay updated.